scientist between University Hospitals University of Birmingham. And here at the Incubator, if it's the first time you're joining us, we host a cross-sector community aiming to collectively advance regulatory science and innovation in AI and digital healthcare. This demand-led webinar series gives us a chance to invite experts on to share their work and insights in key areas with us and create an opportunity to dig into various exciting topics and share ideas and challenges. With that in mind, the format of these sessions leaves plenty of space for Q&A at the end. So soon we'll be able to enjoy the presentation from our speaker today, but you'll notice the Q&A button at the bottom here. So please do feel free to type away with any ideas or comments that crop up as we go along. But we'll save them to the end. So I'll look through that list and either invite you off mute to speak to them or read them out. But don't worry if we don't manage to get to them. As I mentioned, these webinars are demand-led, so even if we don't talk about the questions you ask, it gives us some good ideas to try and line up future presentations. We'll also be recording today's session, which will be hosted on our relatively new website, so you can rewatch it at a later date or pass on recommendations to colleagues who can view it at a more convenient time. So I can move on now to the main focus today, which is going to look squarely at one of the key gaps in the kind of implementation chasm for AI and think about how we should be evaluating AI-enabled systems. Even once they've got access to markets, it can be quite a jump to feeling comfortable about using them in the real world. And it's with great pleasure I'm able to invite Professor Alicja Rudnicka today, who's a statistical epidemiology professor at City St George's at University of London. Alicja has been working in the evaluation of AI systems to detect diabetic retinopathy for 10 years and is also active in the development and evaluation of AI tools to detect and predict circulatory diseases from retinal images. So if I can invite you to join Alicja and share screen. And thanks for joining us to speak about best practices in evaluating AI for screening. I'll hand over to you at that.
Great. Hopefully you can see my screen now. Is that okay? Can you see it okay or not yet? Or not yet?
It's not quite come through yet.
Hang on. Let's try again. Screen 2. Let's try
Thanks very
again.
much. That's looking good. There we are. Brilliant.
Yeah. Okay.
Thanks ever so much.
Okay. Lovely. And I'm just going to thank you very much for the introduction. That was lovely. Thank you very much. It's my pleasure to be here today talking to you all and sharing some of the insights from the work that we've been doing in this space. And I'm going to talk about really best practice for evaluating AI for screening. So in the context of screening, because context is everything. And sometimes these evaluations need to have different nuances to them when you're evaluating them in a different space. And I'm happy to be reached out. If anyone wants to reach out to me afterwards, my email is there on the slide. Can I just check if I move forward, just to make sure everybody can see that it's moved forward onto the next slide?
That looks great. Yeah.
Okay, that's great. So I'm just going to present, I'm just going to get my pointer ready in case I need it. So I'm going to present some findings from a recent evaluation that we did of AI systems for detection, as Jeffrey very kindly pointed out, for diabetic eye disease, which is called diabetic retinopathy. And it's from images from the back of the eye, the retina. So our use case is diabetic retinopathy, but the methodology we've set up could be used in any space in screening that is using medical images, where you're trying to supplement the pathway processes by using an AI system to interrogate the images and provide some kind of useful answer on that particular imaging domain. Just a bit of background about the English diabetic eye screening program. It was rolled out in the early noughties, and it's eligible for everybody over the age of 12 with type 1 or type 2 diabetes and other diabetes when they're age 12 or over. But the thing is there's a really big rising burden of diabetes, with about 640 million predicted by 2030 and even more by 2045. So actually keeping some kind of program going on this basis is very challenging. And I'll explain why it's challenging in the next few slides. And obviously the biggest costs often is dealing with diabetes complications in terms of the NHS healthcare budget. And so the rising cost of these complications mean we need to find ways where we can streamline services to provide still a good service, but obviously it's efficient and at a reduced cost. So in the diabetic eye screening program, when people are invited initially, it was for annual screening. Now there's a bit of a change in the pathway, but I'm just going to focus on annual screening for the purposes of this presentation, thinking about that because that was the area in which we evaluated this domain. When people attend, they have their visual acuity measures. That's how well they can see with their glasses on if they need them in the distance. And then images are captured with a camera that takes images of the back of the eye. Those images are then graded by up to 3 people for the presence and severity of diabetic eye disease, if it's there or not, and how severe it might be. And currently in the last year, there were about 3 million eye screening appointments were scheduled in the last year. And each screening encounter probably generates approximately 6 images per person, because you normally take 2 in each eye, but sometimes extra images are taken for other reasons, or because maybe one image wasn't quite so clear, so they try to take another image that's even better. So it's about 80 million images that need to be, assessed by more than one grader, potentially, and that can be costly and it's labor intensive. Once those images are then graded, there's a potential outcome that there is low-level disease or no disease, and the person is just then either rescreened at a particular interval or come back in a year. Or as from October 2023, some people now come back in 2 years. If there is severe diabetic eye disease known as sight-threatening or referable retinopathy, then they can be sent on to a specialist in the hospital services and potentially be reviewed for treatment if that's applicable. And what we're thinking about is actually putting the AI software at the top of the path, where it might help to triage images for review by humans, so that not every single set of images may need to be reviewed by a human grader. These are the kind of images that are taken in terms of the English National Diabetic Eye Screening Program. So you've got what's known as a macular-centered image, which has got the macula as the center of the retina here, which is what we use for seeing our daily world, so that we can see everything we want to read, such as in a book or on a signpost or train timetable or on your phone. And then on the other side, we've got images that are taken on the other side here, below, are centered on what's known as the optic disc. So 2 sets of images are taken per eye, and these are what are known as 45-degree images. They are then assessed for a level of grade. And I'm just going to bring this up so that you understand what we're talking about when we're talking about different levels of disease and how well the algorithms do in these different levels of disease classifications. The level of retinopathy is R0 for those that don't have any retinopathy at all in their images, and it gradually rises to R1, being mild. Moderate to severe is R2, also known as pre-proliferative, and R3 is then proliferative, which is the most severe disease. And then another bit is of the grading pathway assesses whether the macula, the central area here, has any evidence of diabetic eye disease, and they are known as presence or absence of maculopathy. So absence is M0, presence is M1. And the grades that are below the purple line, so R2, or R3, or an M1, are known as referable diabetic retinopathy, and potentially they should be sent on to the specialist ophthalmologists and hospital eye services to be reviewed for potential treatment of their diabetic eye disease. And those that are graded R0, R1, or M0 are not referable, don't need to be referred, and up until October 23, all of those individuals would have been recalled in 1 year for another screening appointment, so annual screening for everybody for those grades. And the idea is in the existing diabetic eye screening pathway, you're trying to basically filter out between low and high risk individuals. And that's kind of we're thinking with our head on with the AI. That's what we're trying to do, is to actually filter out the low risk individuals who then could come back either in a year, generally, or potentially 2 moving forward, or refer to hospitalized services. And in reality, without just thinking about, not with the QA that's in, or quality assurance that's in place, but in general, what will happen with an encounter. The images are captured, the primary grader then grades it. If there is no disease, it would then suggest that it would go for rescreening. And nowadays, as I said, it's either 12 months or 24 months, depending on whether they have no disease at all for 2 years running, maybe 2. If they have no disease for 1 year or no very low level disease, it's come back in a year. If disease is present, then it goes to a secondary grader. And if they agree that the grade is not referable, then it goes back for rescreening as per specified period. However, if they find that a serious disease, then it could be, you could say, all right, I need to get that into the hospital service as soon as possible, if they both agree over the grade. However, if the primary secondary grader disagree over the DR grade, and it's not a non-referable grade, but potentially one grader said referable and the other one didn't, or it may well be that the grade of the referable they don't agree on, then it has to go to a tertiary grader to assign how urgent the referral might need to be, or whether it actually isn't referable disease and it can just go back for rescreening as per the usual pathway. And so we're going to put AI at the top, and when we're looking at how the AI does in this pathway, we'll be using the human final grade as assessed in the usual pathway as our reference standard. So current best clinical practice, what the humans, oh gosh, let's put to a spin, I don't want my computer doing anything like that, would be to compare it against the human reference standard, which is the worst grade in the one eye. Whichever eye's got the worst grade is the reference standard final grade, because it's the worst grade that actions a change in the pathway. So we evaluated CE class 2 algorithms, or those either with CE1 but seeking class 2 or seeking class 2. And we've used a high volume multi-ethnic national diabetic eye screening program in the Northeast London at the Homerton NHS Healthcare Foundation Trust is where it's located. And really we want to know, is the area safe to triage? Does it work well for all people, regardless of their diabetes type, their age, their sex, or their ethnicity? And we want to know, well, how big do we need to have this evaluation to make sure we do a good job within each subgroup of the population, that we do an equitable job of evaluating these systems in all groups. And these are just the tenets of our approach, in that we engaged all the vendors in the same way. We didn't meet with any individual commercial vendors on a one-to-one basis. We communicated by email only. All the vendors got exactly the same email on exactly the same day. We evaluated all the algorithms in the identical computational environment, so there couldn't have been any issues arising because, well, that algorithm was evaluated this way in that computational environment, or this one was evaluated in a different way, and that can alter how the algorithm potentially might perform. So all the algorithms were Dockerized in our trusted research environment in the same space using the same server throughout. And also it's important to evaluate it on real world data in a real busy screening clinic. How would it work? So the pathway for the individual patients attending for screening did not change. That went on as business as usual. And along the side, we then used their images to be running them through the different algorithms to see what would have happened to those encounters had we had implemented an AI system at the top. And also one of the most important things, which the patients were important for some research purposes, is to safeguard and protect the curated data that we're using in this evaluation. So when we were thinking about, well, how big does the study need to be? We thought, well, we need to probably really worry about the most serious eye disease, which is proliferative diabetic retinopathy, which is the rarest. It only affects probably about 1 to less than 2% of the population at any time. So we thought, well, let's just make sure if we power it right for the rarest, then all the other grades comparisons by subgroups will be well powered as well. And we were particularly concerned about getting enough severe cases, that's R3, retinopathy or proliferative retinopathy, in those of Black ethnicity. Because at the Northeast London, although it's diverse, the Black ethnicity group are the less about 20% of the population. They are the smaller in comparison to 40% South Asian there, and about a similar numbers, well, just under 40% of the white ethnicity. And we would expect a lot of these algorithms from our previous work to pick up the most serious disease, at least with a detection rate, 90%. So pick up 90% of these cases at least. That's what we were expecting. And we thought, well, if we had 100 cases in one subgroup of the population, but we had 600 in the other, and let's just say the detection rate was 94%, then in the bigger subgroup, for example, the whites, the confidence intervals span from near 92 to 96. But if we were in the Black African Caribbean group, where there may be only 100, our precision on that 94% would be less precise. It could be anywhere from 87 to 98. And we're just thinking, well, how big do we need it that we think is equitable enough? So we thought, well, if you are in a position where you would have maybe 300 in one subgroup of the population and 600 in the other, if you scan down the lower confidence interval, which from a safety perspective is what we're worried about in terms of the precision around a particular desired detection rate or sensitivity, then the lower limits of the confidence interval differ by no more than about 1 percentage point. And we discussed that with our senior advisory group and the team, and we thought that was equitable enough. And that's what we went along with in terms of powering our study. As far as who we invited, we tried to find all the global companies out there that have potentially a CE marked algorithm for the detection of diabetic retinopathy only, not just any eye disease, it had to be for diabetic retinopathy. It's actually quite difficult to find all these companies because there's no easy database to search. And since Brexit, we don't have access to a particular other database that used to be able to house all the information that would be quite useful. But anyway, through our various contacts and working in this space for a long time, we thought there are probably about 54 potentially eligible. Through a little bit more searching, we then found that probably 22 met the criteria and that they probably had some, probably class 2, but potentially class 1 certification, and they were specifically for diabetic retinopathy. And we started inviting them in the 30th of June to see if they, 22, to see if they would want to participate. We then had to send, some responded, we had sent reminders for those who hadn't, and then we gave some follow-up information, what the study was all about, what participation for them would actually involve, what would be required. And then gradually some of the vendors then fell off target. A few vendors found us, which was quite nice. They asked to participate in our study. So from this initial pool, we got 5 vendors out of that entire 22, but 3 new vendors approached us. So we ended up with 8 vendors with commercial algorithms wanting to participate in the evaluation. And the reason why some vendors withdrew, even at a very late stage, was that they weren't confident that their ARIAS would work well on our data. They weren't able to deliver the algorithm to us within a 6-month window because we wanted to operate everything offline, not online in this cloud. It had to, everything from our data protection information asset, everything had to be operated on the Homerton on site and not be outsourced to a cloud environment. Okay, so we had 8 algorithms in total. In order to achieve the sample size I showed on the previous slide, we had to curate 2 years worth of data, which encompassed about 200,000 screening encounters, 1.2 million images, a wide age range of people in this screening program, as I said, ethnically diverse, and the full spectrum of eye disease, as well as other diseases people might turn up with when they come for eye screening. Images were captured as usual, and the images and all the grading information and other information that's accrued during the screening program was stored as per usual on the screening database within the infrastructure of the clinical screening environment. So everything went on as business as usual. Only the images were then extracted and put onto our trusted research facility, which is in a restricted access area in the hospital, just the images, and they were then processed through each algorithm in turn, offline. And just to say that the vendors have never had any access to the images from this program for training or development purposes, but we did provide them with a separate data set of 1,000 encounters, 6,000 images, just to make sure that their algorithm could actually produce the outputs that we needed, and it could cope with the variety of different kinds of images that tend to get captured in a program. So for example, although retinal images are what we're interested in here, if someone has got a cataract in the eye, so that's the lens inside the eye is going foggy, or they've got a growth on the eyelid or something like that, then additional photographs are taken at the same time for those which are not retinal. So the algorithm would have to be able to cope with filtering out non-retinal images, for example. Once the processing through the ARIAS was all complete, the outputs from the algorithms were then sent to City St. George's, where we linked the outputs from the ARIAS, not the images, we never received any images, thus the outputs from the algorithms, the automated retinal image algorithms, and we merged it with the screening database information on the demographics of the characteristics of the participants participating in the curated data set. And these are how the numbers play out across all the different groups. So we curated just over, I said, 200,000 encounters, about 64,000 in white, 34,000 in black, 78,000 in South Asian. On average, people were 60 years of age, about 50-50 male, female, predominantly type 2. And this is how the grades play out. So over the vast majority of people have no eye disease, no diabetic eye disease. So about 65%, near 2/3 have no diabetic eye disease. About 20% have a low-level disease called R1, M0, no maculopathy, but low-level background, mild diabetic eye disease. And then those numbers highlighted in yellow are potentially what we would say are referable diabetic retinopathy. And again, about 1% of the most serious disease, 2% of the next level of severity, and near 9% of the one R1, M1. So collectively, these come to just over 24,000 cases of referable diabetic retinopathy, which was probably one of the biggest evaluations of its kind in such a large number of those with referable disease. And I've highlighted the blue number just to remind me to say that we hit our recruitment target and that we wanted at least 300 cases of the most serious eye disease in the Black African Caribbean group, and we managed to exceed that, which was great. And this is how the scores on the doors play out. So the primary outcome is, does that case, that encounter, have referable disease, yes or no, as per the worst eye grade according to the human? So the human reference standard grade, referable disease, yes, no. So that's what we mean by here, yes or no. And then was the automated retinal image analysis system algorithm, did it say it was test positive? And what we meant by test positive was that the algorithm thought there was some level of disease present there. Now, the different algorithms have different thresholds of what they mean by disease is present. So according to that algorithm, it thought the disease was present or was unable to assess it. Perhaps potentially there was a technical failure in the system, or the image wasn't of good enough quality for the algorithm to be able to make a decision. So if we have that sort of scenario, that would have to go for a human. So test positive means algorithm thinks there's disease there, plus couldn't assess it. So amongst those that were test positive, where the human has said, yes, there is referable disease, the detection of those ranged from, so the sensitivity, in other words, ranged from near 99% for vendor E down to near 84% for vendors D and H. So that's a sensitivity because the algorithm picks it up and they have the referable disease reference standard. Conversely then, when there is no referable disease, some encounters would still test positive by the algorithm. And again, for algorithm E, near 70% would test positive. So algorithm E is generally very sensitive and not very specific. All the way down the false positive rate, because it's not referable disease, but the machine says there's something there, 13.5% for vendor D. So vendor D is very specific, but just not quite as sensitive as vendor E. It's quite interesting to look at E and D. I've pointed those out at the extremes, so it's quite interesting to look at those on the next graphs. And then the two bottom graphs are just the other side of the coin of the top. So this graph just here, the false negative rate, is just the top one taken away from 100%, because that's where the areas were test negative. And obviously there are all the 8 vendors along the bottom axis here. And the specificity again is just 100% minus the false positive rate for the different vendor algorithms A to E. I'm just going to unpack this just a little, dive a little bit deeper into this one. I'm particularly worried about the more serious levels of disease. So I'm going to show you a sequence of graphs for now that are going to repeat. So I'm going to describe the scale once, and then we'll just flick through them. And it's just a visualization of how well the algorithms do compared to the human. So on the vertical axis will be the sensitivity or the detection rate, meaning that for that particular grade that will appear on the graph, the algorithm said test positive. And there'll also be something from PG, what's known as the primary grader, and there'll be 2 values for the primary grader, which I'll explain in a minute on the next graph. So either the primary grader value or the value for all the different algorithms will be displayed on the horizontal axis. Then the symbols are, the dot in the middle of every symbol is the estimate of sensitivity. How good is the detection for the human or the algorithm? That's what the numeric values are going to be plotted. And the error bars are what's known as 95% confidence intervals. And the different colored symbols will represent different subgroups. And I'm just going to show you today just age and ethnicity in the time that we have available. And the blue dashed line is just where, if we were to look, the blue symbol in this instance is all subgroups together as one for the primary grader in terms of a quality assurance standard. Where is that bottom confidence interval for all the groups together for the primary grader, where it thought that the particular disease entity was actually a referable disease. That's what the primary grader was thinking. So I hope that's okay. And that dashed line will appear in the same spot on all the graphs for that particular disease entity. So the first disease entity we're going to look at is R2. So that's moderate to severe diabetic retinopathy, either with or without the maculopathy. And I've got some numbers on the side of the slide here on the right. And I've just given you just a ground of the numbers that you're seeing on the graph. So they are the percentage that were classified as referable by the primary grader. So when the final reference standard was R2M0, how many times did the actual grader, primary grader, say, yep, that's referable? And as we can see, they're very good at it. They say 95% of the time they thought, yep, referable disease is there. And then the orange is for, so the blue symbols are for overall, the orange are for the white ethnicity group, the black ethnic group are in green, South Asians are in red, and the other or missing ethnicity are in purple. And on the graph over here, so we've got the sensitivity here, so these values just here are plotted all over here for the primary grader. So this is where the primary grader thought it was referable. But the primary grader is actually very capable of doing more than that. They'll actually tell you whether there is any disease present. So that's the next level for the primary grader. Primary grader thought disease was present. And this is then how all the other algorithms play out, A to H. So although let's go back to vendors D and E, although they were at the extreme ends of sensitivity and false positive rates on the previous graph for all referable disease grouped together, when we're looking at just this subgroup of R2, they are remarkably similar to one another and performing as well, if not better, than the primary grader, as do all of the algorithms generally. And I'm just going to go up the grades now. So let's just do the next one for R3. So these are the values for the primary grader, classifying it as referable, and they're over on this side of the graph. And then all the other algorithms, how they play out, and the primary grader saying, oh, I think disease is there, which is obviously a little bit higher. And then for R3A. And R3A is what's called active R3. That means that is potentially the most serious diabetic eye disease, and that would need urgent, fast referral to an ophthalmologist in the hospital. And I think you'll agree that in general, all the algorithms are doing remarkably well, and as well, if not better, than the primary grader. And most of the confidence intervals for most entities are hitting above that blue dotted line. Then if we have a look by age group now, it's exactly the same thing, but now by age. And interestingly, for the primary grader classifying things as referable or not, in terms of this grade for R2, which is a pattern you'll see on the graphs that come forward, they tend to get less good as patients get older. Because obviously these are the 75 plus group, and the blue ones are the youngest age group, which we looked at specifically because we're particularly concerned about the younger age groups. Maybe the retina is more reflective and you don't get such good images. Maybe it's more difficult to grade R2 accurately from an image for an algorithm examining that image. So that's why the error bars are a little bit wider there. But in general, all the algorithms did as well as the human, and they all some of them show a similar pattern to the human in terms of, for example, reducing performance with age of the participant or the person being screened. This one shows it, this one, this one, this one, and this one. And again, a little bit of an evidence in some of them here, but not so much. But for the most serious disease, they are doing remarkably well compared to a primary grader. For the 75 plus group, our error bars are a bit wider than for the other groups, but then that's just because there weren't that many cases of the most serious disease in this particular oldest age group. It was just a less common occurrence. And then you might think, well, what about, the cases that you miss? And when in screening, generally, if someone we decided that to comply with the current pathways, if someone was ARIAS test positive or they had a visual acuity, what's known as less than 612, so if their acuity was down, then they would have to go and see a human, because currently in the pathway, people have reduced vision, follow a particular pathway. So we thought, right, well, let's see, what are we missing then? If the algorithm says it's negative, can't find anything, and their acuity is absolutely fine, how many cases would we miss and say, come back next time, see you in a year? So of the ones that were the lowest of the referable grade R1, M1 and had good vision, we had just under 15,000 of those. But only a small proportion of those would actually have been missed by the algorithm that were urgent referrals for diabetic eye disease to ophthalmology departments in the hospitals. Those that were referred to ophthalmology that were not urgent, slightly more of those are missed, but still they're quite small numbers, less than 1 percentage point. For the next level up of retinopathy, the numbers are very similar to up above. They didn't miss any that were urgent referrals, but some that were referred to ophthalmology. again, less than 0.5% most of the time. And then for R3, the most serious, then the urgent referrals, again, less than 0.5% most of the time, and a couple of them, maybe 1% or 2%. So overall, so if we add all of these up, in terms of these pooling these all together, missed cases of referable, who had good acuity, there were near 19,000 of them, and the percent that were actually then referred to ophthalmology were very small. And again here. And you have to put this in the context of what a human grader might miss. Because although this is what the grading pathway would have suggested needed to be done, then there is another grader that decides whether this actually needs urgent referral or not, or whether we just rescreen them in a year or rescreen them a little bit more frequently. And in a report back in 2015 by Scanlon et al., it was estimated that human graders misclassify what's known as true referable sight-threatening diabetic retinopathy about between 2 to 4% of the time, depending on whether there is maculopathy or not. So this miss rate of humans is not a million miles away from what we're seeing with the algorithms in this space. So what have we shown? I think in terms of tenets of screening, I think we've shown that it's as good as primary graders, especially for the most serious disease. We know how well they're performing. Looks like it's pretty equitable for, not all, but for most of the algorithms, because some of the older age groups were not so good for some of the algorithms, but some of the algorithms still did very well. So you may not want to use one algorithm for everything, might use one algorithm for those cases and a different one for other cases. And it can be integrated as a primary grader in the pathway. We've done some pilot work on that, but we still need to look at the cost benefits now. We've already done some cost effectiveness analysis a long time ago, but that's when it needs to be updated now because it is just simply out of date. But potentially the ARIAS could offer a massive cost savings, because you can imagine for algorithm D, probably less than half or 20% of the encounters would need human grading. That's a massive workload reduction for the primary grader. And there is an effective treatment. At the moment, generally, of all people referred for proliferative, that's R3, probably around about half receive treatment. For those referred for maculopathy, about 1 in 5 will receive treatment. So even if they're referred, that there isn't necessarily going to be a certainty that there'll be any treatment given. And screening is a form of intervention, so it carries consequences. And so I think, with the expected rise in diabetes prevalence, in order to be able to maintain this service, we need to do something. So if you're interested in the methodology that we have published, our head-to-head evaluation on a diverse, real-world target setting population to avoid bias and be equitable in power, then there's a QR code to our paper there. And it provides I think for us, it's provided a real clear pathway how we can do this again, but more quickly for updates of algorithms or new algorithms that come along. So we think it could be used to safely triage for screening, reduce the need for everything to be screened by a human, by anything up to 65%, which is amazing, and protects the provision of the service, allows it to keep going. Now, in the few minutes that I have left to speak, I just want to go very quickly through some other activities that we've done, which is we spent quite a bit of time talking to healthcare professionals working in the service and people living with diabetes, what their perceptions and concerns were if AI was to be brought in. What did they think about it? So we thought, well, we kind of, back then, people are more familiar with AI now. There's been a big culture shift, but generally back then, the whole notion that AI might be brought in into healthcare was, was scary for some people, and people didn't know what it was. What does it do? How is it going to change? Is it going to work for me? So we decided we'd need to develop a survey to find out people's views. We went to 3 big centres, North East London, South East London, and Gloucestershire, and we worked with staff and people living with diabetes to co-design a survey, which we then validated for wider rollout. And then we did some analyses, and most of the questions were Likert type questions, but also some standalone questions which didn't actually fall onto a sort of a Likert scale. And then to try and help us decide, well, what do we need to do for outreach? What does everybody want to know? What training do they need? And what does patient information need to look like potentially? What is it they're concerned about that we would need to make sure our facing material addresses? And the timeline is, it takes quite a long time to do these co-design surveys. You've got to get approval first to do the co-design work. You then co-design a survey. You've got to get approval for what you've co-designed before you can actually roll it out, to do some validation interviews, tweak the survey, get those amendments approved, and then you can do your wider survey distribution and then analyze and then think, gosh, what do outreach need to look like? And we're at this stage now, we're doing this now, but we've done all the top 4 boxes. So just a quick little whistle-stop tour. When we co-designed this survey with people living with diabetes and healthcare professionals, the questions kind of fell into these domains. So very similar between the 2 groups. We sort of came forward with some questions, but then we co-designed new questions of things that they really wanted to know about. And our methodology paper linked to the QR code is just there. I think there are a lot of things that are still relevant, even though it's a couple of years ago when we designed all of this. All these questions are still relevant. And we recruited quite a large number of people living with diabetes. Over 1,000 of them participated in the survey, which was great, from the different sites that we recruited. And also we had healthcare professionals from different screening centres that participated in answering our survey questions as well. And what I really like is that we've got because it's an online survey, so people say, oh, you might not get all the older people who have diabetes to respond to the survey, but actually we've got good numbers. You know, a large number of them, you know, everyone uses a phone. You could do the survey on your phone. You didn't need a computer. You could just follow the link. The survey link was texted to patients in the screening services that kind of communicate with their patients that way. And then they completed the survey and we got the results back electronically to analyze. And here are just some answers. I'm not going to spend a lot of time talking about every single answer, but just to show you, for example, healthcare professionals, what are they worried about? Oh, benchmarking. So one is, yeah, I agree, I am worried. A large number are worried about being benchmarked against the AI. Barrier to acceptance, not knowing how it works. Does that bother you? Initially, that bothers them. We spoke to a whole stack of them again yesterday. They're actually not so worried about it now. So there's been a big culture shift in how people perceive or think about AI. A lot of patients, lovely, they don't mind their data being used for research, which is great, near 80%. And a large number of them wouldn't mind actually receiving their screening result by a text or an email. You know, that saves thousands of paper letters being sent every month. I'm just going to flick through some of these. What are the healthcare professionals worried about? Quality. How are we going to check these AI systems are any good? Well, I've shown you how we've done it. And so far, everywhere we presented the work, healthcare professionals have been very pleased with what we've done. Who's responsible for the errors? That's always a big question when you bring in new tech. Who takes responsibility? And obviously, people living with diabetes were thinking about their data security, quality checks of the AI systems, and responsibility for errors. Very important. Who takes responsibility when things go wrong? Some of the things people were more concerned about were, will it alter my screening experience? Because it's interesting, it's really funny. People thought when we're going to bring in AI to look at images, we told them it's a computer program that just looks at the images that you have taken at your routine appointments. They, for some reason, thought that they would no longer see a human. We never said that. We just said, you have your screening appointment as usual, and your images are taken and analyzed by a computer. What do you think of that? They thought that somehow some robot was going to be receiving them at the screening center and they actually wouldn't see a human, which is not true. Healthcare professionals thought maybe it might give us a bit more time to do other activities with patients that are needed in terms of personal communication with them or face-to-face. They were concerned, would it lead to less personalized experience? They were concerned about that, but obviously we need to educate them that what you do will carry on very much as you do. Normally, it's just that what's happening in the background after the visit is ended, it gets processed by a computer and so on. I think I'll just leave that one there. And just, we looked at Likert scores across, we had probably about 20 or so questions in each survey. And a mean score above the line means the Likert score has a positive view of the AI system, whereas 0 is neutral and anything below the line would be deemed as negative. And so this symbol here actually was negative questions. Sorry, that should have been actually below the line. So otherwise, if there was some workforce, people worried about losing their jobs. So yes, they were very concerned about that. And obviously some concern about the patient-practitioner relationship. But otherwise, in terms of positive aspects of the AI and on the workforce, increasing capacity, trust, data security and efficiency, and general questions about AI were positively received. So positive attitudes from people across the board, which we were surprised at because we thought that we received much more negative interpretations. I won't go through this. I think it might take a little bit long time to see. I won't give time for questions. So what are our next steps? So we now know what our outreach from our PPIE would need to look like. And we've got, as I said, the methods paper is on the QR code on the left, and the other paper that we've had on some of the qualitative assets published is given on the QR code on the right-hand side there. So from the work I've just presented, we know what we need to do. We know what information the healthcare professionals want and the patients want. We have a prospective real-world evaluation in the intended healthcare setting. And what we'd like to do now is do big live pilots. so we can map out the proper pathways properly. We have a prototype, what's called an API, because we'd like to be able to have what's called something that's vendor neutral, that you don't wed yourself to one algorithm forevermore. So we'd like to develop an application interface where you can plug in that, take that algorithm out and take that one, or have more than one algorithm in a system, because that one's really good for those particular groups of population, whereas that one's really good at that subgroup. So let's have more than one algorithm operating at any one time. And that the choice of algorithm for deployment, that choice remains within the control of the NHS rather than the vendors. And obviously, I said we're doing our health economic analyses now, so maybe at some other time we'll be able to update you on the health economic aspects of the work. We assume they will be cost effective as they were years ago. We showed it would save probably about 80 million per year if you could bring them in back then. So the chances are, if cost of the algorithms is as sensible as it was back then, there could be potentially large cost savings and efficiencies to be had. I didn't do all this on my own. A fabulous team, and I'd like to say thank you to them all. And they're in the photograph here. That was at one of our last closing meetings on the project, when we had finished all the evaluations and we were then just working on the analyses and writing everything up. And they're across different institutions, both NHS care, universities, and I'd also like to very much thank the steering advisory group that helped us with this. That's Alicia Dennison, Ros Given-Wilson, Kevin Dunbar, and Fiona Martin. That was our lay representative. They gave us super advice. And obviously, I'd like to thank the funders for funding this project. And we call ourselves the ARIAS Research Group. So we are the Artificial Intelligence and Automated Retinal Image Analysis Systems Research Group. And that's all I have to say. So thank you for your attention. And I can stop screen sharing now, I think.
Thanks so much, Alicia, for such a clear account of an amazing body of work. The scale, just well, in terms of the number of cases and the number of vendors you managed to engage, is amazing. I've certainly got a few questions myself, and we've got some coming through the Q&A already. Those of you online, please do pop any extra questions and comments into the chat. Just to kick us off, Alicia, I was wondering if you had any tips of how to kind of negotiate or manage such a number of vendors in a head-to-head evaluation. I think it's really valuable to be able to compare different products like that on the same data set.
Yes.
But I know those conversations from personal experience can be difficult, and getting people on board to have transparency about the results and stay with you along the way is really tricky. Any kind of pearls of wisdom from your experience?
Well, I think we've worked in here for a long time, so I think a lot of the vendors that took part knew us already. So I think that helped, but I know you've got to get started somewhere. And I think that we gave very clear communication all the time, and we gave the same communication to all the vendors all the time, same day. You know, no one got it early. And there was a Q&A. Lots of vendors raised questions. Some didn't, some did. So we provided an anonymous Q&A that we then shared with all the vendors so that everybody got the same information. So I think we've tried to show that we're very transparent about what we're doing. And I think that was important, you know, giving them a test set to play with. And we helped them, you know, we had to spend quite a bit of time. We had a really lucky, good relationship with Homerton IT, which is no mean feat in the NHS these days. Trying to get a good relationship with IT to help you run a study is really hard. But we also had an individual working with us who was a very good programmer. So some of the vendor algorithms didn't do what we wanted them to do. So he actually got into their source code and sorted it out for them, which is quite incredible.
Oh, wow.
Yeah, so at the beginning, it's just like the first step often, they didn't set it up right. And so he helped. And then also we fed back the results, not everything to them yet, but just for their algorithm, for the most serious disease, we've already shared the results with them as soon as we could. And we've kept them involved in the process of what we're doing. So as soon as that methods paper we shared it with them. As soon as it was available online, we shared that with them, and we keep them informed about, you know, we've submitted our results paper, but which we have. We're responding to a second round of comments, which I hope will be the last round. And so I think they are asking us, you know, what's happened to the publication? When is it going to be out? And so they've actually been very positive. And when we've asked, we want to take part in live pilot studies, would you be interested in participating with us? And most of them have said yes. So I think it's about clear communications and the same communications for everybody. And I think good advice was given that we learned from our previous study was not to meet, I know this sounds terrible, but not to meet with any one vendor individually. Because that way you can then guarantee you're giving everybody the same information. There can be no ambiguity because everybody's got the same email. Everyone's been the same level of information to the same depth. So there can't be any miscommunication. And I think that's what's key, really.
No, that's helpful. And good to hear the results will be out there soon. I see there's already one question about where they might be available. So
yes,
thanks for sharing.
They'll be de-anonymized then. We've anonymized them for now because it's commercially sensitive, but obviously it's pretty useless having a paper out there with anonymous names. You want to know the names of the algorithms. So we will publish open, as we've done with all our papers.
That's fantastic. Next, if it's okay, I'll just tee up two shorter questions together. The first relating to what you've already mentioned, which is how long the study took, such an impressive body of work. And this second, more of a clinical question, and it depends, maybe a big part of the answer, but just about a sense of how long it takes for eye disease to progress from R2 to R3.
Oh gosh, yeah, that's a very good question. So R2 to, we've published on that actually. I could find that paper for you because we've done it. Yeah, let me try and find that in the chat actually, because we've got the I'll try and find that paper for you because we've published on progression rates. And to go from gosh, for me to remember the progression rate from R2 to R3, gosh, I can't remember exactly, but you don't necessarily progress that quickly depending on really how old you are, what ethnicity you are, and how long you've been living with your diabetes already. So that will alter how quickly you progress. And generally, it's quite interesting that those of non-white ethnicity progress much more rapidly up the grades than those who are of white ethnicity. And how long did the study take? And let me just find that other papers on. I can pop it in the chat in a minute when you're wording your next question.
Yeah, okay, thank you very much. That's really helpful. I'll come to one more question, and then I've got a question I'll invite an attendee to speak to as well. But how did you decide on an operating point for the AI tools in the study? And I'm just anticipating what your response may be there if you didn't, because that was in the hand of the vendors. Have you got any thoughts on the rationale that should be held for trading off sensitivity and specificity and making those threshold decisions?
Well, I'll just say I put the progression rates in paper in I think it's like progression rates. I'll put that in there from BMJ opened diabetes research and care. So if anyone wants to know about progression rates, there's quite a lot of tables in there. Because these weren't just any algorithm from the world out there. They all had to have a CE mark or be seeking CE mark, preferably class 2. When a company submits their algorithm for that, a threshold has to be set. An operating threshold is set by the company. We don't set it, they set it. So that's why you end up with different levels of sensitivity and specificity or false positive rates, because the algorithms have been developed and set different to each other. So we don't set it. But they are global companies, so they haven't been particularly developed or tailored to the English diabetic eye screening program, feature-based grading of diabetic retinopathy. They've generally used the international classification for grading diabetic retinopathy from images. So they are all international companies. So they would have had their own priorities set on where they want their operating threshold for their algorithm to be.
Just as a kind of variant of the question, for whoever has the unenviable decision of picking which of these tools to run with, say for NHS screening service, what kind of process or rationale should lead them to pick the balance of sensitivity and specificity? Let's say we've got sensitivity that surpasses the current primary grader.
Yeah.
How might that process of figuring out how much we want to increase sensitivity versus how much we want to improve efficiency, I suppose, through...
Sure.
Have you got any thoughts on that?
Well, we are going to try and, in fact, there's a meeting coming up soon where we're going to try and discuss how best we manage those decisions. I think potentially all of these algorithms are deployable. And But the fact that some of them have not such a good specificity compared to others is a cost effectiveness analysis, which we haven't done yet. So it may well be that one algorithm maybe is incredibly cost effective, and that might be at the cost of a slightly lower sensitivity. But for the most serious disease, they're all doing extremely well. And I think we wouldn't wed ourselves to one algorithm. I think that's a mistake. I think you would have a range of algorithms that are potentially deployable. And you might say, these are really good for all of these groups of people, but maybe if you've got very older people, maybe you should be thinking about using this algorithm. And I'd like to be able to think that, which is what the clinicians said actually years back, that we may well find that certain algorithms work better than others for certain groups of people. So I don't think we should wed ourselves just to one algorithm.
That's interesting, sort of MDT of algorithms.
Yeah.
Next, I'm gonna unmute Lukash, if that's okay with you, Lukash, just to speak to your question. Hopefully, we should be able to hear you now.
Thank you very much, Jeffrey. My name is Lukasz. I'm based at the Health Foundation. I just have a question about how those algorithms are likely to perform in the real world scenario, whether taken in the context of the pathway, and whether the results of the algorithm are likely to have an impact on the secondary and tertiary graders doing the assessment subsequently.
Well, this was a real world evaluation because these were real people. It's not a research study. It was just done in silent mode. So I think in terms of anything in terms of integration, it's just to do with a digital integration rather than them algorithms suddenly performing differently in the real world. The humans might perform differently, of course, but we would probably follow something similar that happens already in the program, in that when graders review other graders' encounters, they are doing it blind. They do not know who was the previous grader, nor what they said. So for us, actually, in putting in the algorithm as if they're another new primary grader allows us to maintain that anonymity, so as best as possible not to bias people's responses by knowledge the algorithm said there's something there, or that it said that it, because obviously they'll still have a certain number will go through quality assurance. So as for the human system, even if the primary grader said there's nothing there, and if the ARIA says test negative, we'd still send a proportion of those for higher level grading anyway as part of the ongoing QA that's in existence already in the pathway. But ultimately, I do agree, what will happen is that the humans will know that I'm predominantly getting encounters where the machine thinks there's something. And I think there might be initially there'll be a bit of caution and maybe taking a bit longer to grade as systems bed in. But then I don't think it would hugely have any diagnostic bias effect as it does in other areas where the human can see what the algorithm has said, in terms of it can see what the grade is, or it can see what it's focusing in on that image. So you're much more likely to bias a decision process from the human that way. But I think the digital pathway is a bit that we need to work through for sure, because that hasn't been fully, they haven't been fully integrated yet. They've just been done in silent mode off to the side in a real world program. So this was a real world, this wasn't a research study in that sense. They weren't recruited to participate in a research study. Does that answer your question?
Yes, absolutely. Thank you very much. Sorry, I didn't mean that wasn't in the real world, so I meant more in the context of the pathway, but you've answered my question. Thank you.
Okay, thank you.
Thanks very much. I've got one more question. The Zoom has badged as anonymous, so I'll just read out. How open are the vendors to the NHS having control over which system they use and being able to swap them? They can understand that they might not enjoy the idea of not having a monopoly on it or some kind of vendor lock-in. How do you think that'll be managed?
Well, I won't be managing it, thank goodness. I don't know how they feel about it, but I think it's the fairest way. We do it for other things, other medical devices and drugs. You know, it's open label, who's doing which one. We don't have to always buy drug A from company X. So I think there'll be, it's all about commissioning, isn't it, really? And then it becomes about opening commissioning, and maybe knowing how, you know, the algorithms, when they participate in evaluation like this, the company will get unbelievably valuable granular data. I mean, I've shown you a snapshot of what we've done, but, you know, through all our supplementary tables, honestly, we've got about 30,000 numbers showing how the algorithm performs in different scenarios, different subgroups, different ways of different grade, every single grade. We've done every single grade for every algorithm. So they will get unbelievably valuable information to allow them to learn where their algorithm could possibly improve for this UK market. So I think it's very valuable. Will they not like it because you're going to be plug in and plug out? I guess one would hope that it would create a more level playing field and healthy competition rather than a monopoly.
No, that's really helpful. Can I just ask one final question, if that's all right?
Sure.
I was really impressed by the table you showed, thinking through the powering by ethnic group. And I can see in diabetic retinopathy, disease prevalence and other characteristics vary across ethnic groups, and it makes a lot of sense to power studies in that way. Just thinking in other contexts, or if you were going to think about other characteristics that you should be considering through the powering process, have you got any advice on how to arrive at that? You know, whether it should be ethnicity, whether it should be age, whether it should be, say, myopia in eye disease or some other characteristic? Because it seems like a challenging issue to dig into.
It is. I think it depends what you know are the most important characteristics that might alter presence of the disease, you know, how common the disease is and how severe it might be. And we were particularly, why age, because people who are older, their images are more difficult to see because they might have other, you know, like a cataract or something. You can't see the retina very well. So we thought we want to make sure it doesn't perform poorly in older people potentially. So maybe we should have actually powered it a bit more for the, initially we weren't going to do the 75 plus group, but then we just thought, gosh, we've got so many people over the age of 60 here. We need to really split that age group up and split it up a little bit further, but we just didn't have enough people in the over 75s to get very tight confidence intervals, and there weren't that many cases of R3A there anyway. But I think you just need to think about what's important to know about, and from eyes, imaging eyes, obviously the level of pigmentation in the skin can be very different. So the level of pigmentation at the back of the eye will also look different, and that may well alter how algorithms function, because the retina is systematically different between people of different ethnic backgrounds because of the level of pigmentation, which might alter how an algorithm might work. And I think also when we went for the grant funding, this all came out when the whole pulse oximeter issue arose, where, you know, the skin pigmentation might alter how the pulse oximeters were working. So ethnicity was an obvious one. I think we've always had a long-standing interest in ethnicity. Age, because you know, how old you are may alter how good a quality image you might get from the back of the eye. So I think they are the main ones. But we looked at IMD and sex, diabetes type, just in case, and we didn't find anything. So
that's really helpful, and thanks so much for joining us this afternoon. It's been brilliant. Really enjoyed all those insights, and it has a lot of relevance. I know how important the context is, but outside of screening and other applications. So thanks so much.
You're very welcome. Thank you for inviting me.
And thank you to our audience too for some great questions and dialing in. And we'll look forward to seeing you next time, I hope. And
thank you.
Enjoy your evening.
Yeah, you too. Bye-bye.
Bye.